uh, working as a neurosurgeon in CMS Dhaka. Welcome to this topic. It's a different topic for you, I think so, but the common sharing topic. The
Recording in
cervical part,
progress.
endonasal corridor for intracranial lesions. As a ENT or otolaryngologist, you are very much aware about this nose and paranasal sinuses because these are the intensely related with the anterior cranial base going through the brain. So we neurosurgeon also like these places that how can we directly hit the lesion without cutting the skull. I'm very much thankful to the organizing committee here and my elder brother come friend who is always beside me inviting me here last time also this time, and the directors are for attending these conferences with create immense interest for me. That's why I'm here. This work is, I have no financial issues. It is totally academic presentation, and my patients and others ethical clearance for the consent and ethical clearance is taken from the competent authority. As you know, uh, natural orifice surgical procedures. This is a very popular and very interesting subjects for all the surgeons who are working in different parts of the body. So, as a ENT surgeon or neurosurgeon, going through the nose or paranasal sinuses using the natural corridor, natural orifices is very interesting. As you know, extracranially, the anterior skull base is inferiorly related to the sphenoid sinus, the nasal cavity, and the orbit. So here, I will focus on my talk on my talk on the nose and paranasal sinuses. How can we use this avenue, rather not corridor, but avenue for entering into the brain to treat the intracranial lesions? Because this is the way where we can directly target the lesions. There will be no brain retraction. It is our part because we sometimes after surgery, brain retraction can cause a lot of problem. Even doing good surgery, but outcome may not good. So we can avoid brain retraction. And obviously, the celebrity will like it that this is scarless surgery. There is no surgical scar. Then minimum blood loss, minimum hospital stay, then improvement in the quality of life. These are the all advantages. Uh, uh, that's why we use this corridor for intracranial lesions. Endoscopic endonasal surgery provides access to almost all regions of the skull. That's why we call it 360-degree approach. You go anteriorly, you go laterally, you go posteriorly. Anterior skull base, even going through the nose, not only the anterior skull base, I will show later, we can go in the posterior skull, posterior cranial fossa, especially cipiangle region. When we remove the clivus, then we can go beyond this, the basilar artery, the brainstem, and all this. So, you must be popular with with using the nose as endonasal route, either transseptal or endoscopic endonasal, transsphenoidal, endoscopic endonasal, transigmoidal, endoscopic endonasal, transfrontal, or whatever may be route. This is a good place. Earlier, the neurosurgeons also use the sublabial space, for pituitary surgery using the microscope, going through the sublabial route, going through the nose, then remove the pituitary one. And obviously transmaxillary, transpterygoidal approach, some middle cranial fossa lesion, we can go there. And this transorbital, though is not popular here, but we can go directly hit this area going through using this route. And like our ENT friends, we are most thankful to Oscar Harsh, who in 1990, the otolaryngologist introduced transseptal route, transseptal transferal approach for removal of the pituitary tumor. Later, the great neurosurgeon, you have heard about his name, Harvey Cushing. Harvey Cushing is famous for the pituitary surgery. So he adopted this thing, and he also used the illumination system and a microscope system to remove the tumor using this transnasal route. So just recapitulation, why there is surgical freedom here. We usually use either endoscope or microscope, but we are very much concerned about using the endoscope, because endoscope has an versatile use by its mobility, by its going, you see, if I use the microscope, the eye is here, we can see the lesion there, but if we use the endoscope, we can bring the eye towards the lesion, and the vision is you can see here, the vision in endoscope is widely angled from 0 to even 120 degree. Some scope even 120 degree we can go, but in microscope we use the tunnel vision. So we refer to this endoscope in such corridor for wide vision, then hitting the target and giving all the advantages. As I have told you, that once the anterior base, I'm not moving around the nose and paranasal, beautiful lectures, beautiful CT scan lecture, then beautiful live surgeries in how nicely and vividly the paranasal, nose and paranasal sinuses dissection I have seen. But if we remove the cellar floor, then remove the planum, then remove the clivus, we can go beyond these spaces. That's why my topic is here, looking beyond paranasal sinuses. If you see in the endoscopic cadaveric view, you can see here that this is the structures within the brain. Once we have removed the anteriorly the planum, then the cellar floor, then the clivus, and even the odontoid. So we can go from the anteriorly cribriform plate to the C1 C2 junction. So then we can remove all these lesions in the midline. And there is some limitation in the paramedian line or lateral approach, because this has got some limitation that, but even going through this, you can hit the lesions in the cavernous sinus. This is very popular also. So all the lesions here, not only the pituitary, the other lesions like meningiomas, like chordomas, like schwannomas, all this can be dealt by this route. We have done during our cadaveric work fellowship in 2012, we have done in one series that whether we can deal with these vascular lesions. You know, the aneurysm in the anterior circulation is also related or nearly to the pituitary gland. So those endoscopic surgeon who deals with the pituitary lesions, then I know someone here, and very expert one, that they are doing the pituitaries. So they have to be aware that there is some vascular lesion, aneurysm that mimic with the pituitary lesion sometimes. So that can be a big havoc. So vascular lesions, we are trying to whether we can deal this thing through this route. This is the CT imaging. As you see in the sagittal plane, there is level already discussed in previous lecture, so I am not going through it, but you can see that from frontal towards the cervical junction or craniovertebral junction, we can approach. This is a very interesting slide. Those who deals with the endoscopic surgery in the anterior skull base, if you starting from, especially for the juniors, if you think that starting from the level 1 to level 5, if you can think that which level I can target, you cannot, then it will be safer to deal the patient, because you have to know which lesions we should do through this approach, which should not do. This is very important. You can see once you are master in dealing with these endoscopic skull-based surgeries, then you will very much be able to understand that which lesion can be easily done and which lesion can cause problem to you. That I will come later, that we may face a lot of problem while doing these surgeries. So this level approach is very important for the learning curve period. The common lesions that in the around cellular, supracellular and paracellular region, pituitary tumors, or maybe functioning or non-functioning, it may be big macroadenoma or only the cellular region, but it can expand around the paracellular region. Then the craniopharyngiomas, then meningiomas, then other things like thick lap cyst, sinonasal malignancy. We have a good ENT team in Dhaka CMS. I proudly say that Professor Tohid, then Bashir, then Iftikhar and other. So they are very much helpful to us while dealing this type of malignancy, sinonasal malignancy. We combinedly go and deal these things. Then some uncommon lesions like dermoids, doing some optic nerve decompression. These are things we routinely do. As I have told you, what are the limitations in dealing with the lesions beyond the paranasal sinus by endoscopic route. It depends upon the size of the lesion. If it is a huge lesion, if we cannot encounter this lesion, so we can just debulk this thing, but sometimes it will not suffice to remove that lesion. So it is a limitation to go to the endonasal route. Then extent of the lesion, far laterally lesions, we have to be very careful. Vascular involvement and encasement, especially the meningiomas or the huge pituitary tumors that can encase the ICA and its branches. Then presence of intact olfaction. Sometimes it's difficult because the patient is having intact olfaction after surgery. Patient is not happy that olfaction is gone. That's why it can lead to lower rates of resection of the tumors, higher rates of CSF leak, postoperative impairment of olfaction, higher complication rates. Therefore, patient selection is paramount for achieving a successful result with avoidance of complications. Just I will, for the audience and for the juniors, I will just next slide, a few slides show that for development of endoscopic endonasal surgery, what you should do. You should intense cadaveric workshop, conferences, fellowship. These are very important. Once you have qualified post-graduation, a lot of workshop you have to do. As this institution is doing, I'm very proud that they're doing nice workshops here. Then the cadaveric workshops will be coming later. Then selection of the cases that you are doing pituitary cases, but we are as a neurosurgeon we have to deal far beyond this one. And also if you are interested to read more books, I have a book chapter and also some publications, very good things there where other than pituitary, especially they have meningiomas, we have published their experiences, and also on cadaveric dissection of the vascular lesion. This is important for the juniors, I must say. Now I will show you a few cases. As you are aware that all cases, the selection of all the cases is not important, but the selection of the cases that can be dealt safely and can give good result to the patient is very important. Pituitary macroadenoma, you are familiar with this thing. Sometimes big pituitary causing mass effect on the optic chiasm, causing visual dimness. This is the common indication, but those tumors which are smaller in size, even not macroadenoma, even this microedema is very difficult to identify in the MRI, but the patient is symptomatic, especially the Cushing's, then the acromegalies. These two notorious functioning pituitary tumors, the tumor size may not be bigger, but the smaller tumor can make the patient symptomatic. Sometimes life-threatening. A patient having acromegaly, small tumor but high growth hormone secreting or IGF secreting tumor. You may not find out the tumor is very small, but the surgery is the option. The answer is the surgery. If you do surgery for acromegaly and the Cushing, if the correct surgery is done, patient may remain symptom free, or the disease recurrence may not come so quickly. So this is a case of acromegaly patients. You see the patient has developed the face exchanges of the nasal bones, then the lips, then tongue, having problem with obstructive sleep apnea, then having intractable diabetes not responding to medication, then having heart problem with hypertension and other thing. You see the acral bones are here. You see here the pituitary macroadenoma. Though if you see the laterally, the IC encasement is not severe enough. But even though if the tumor remains smaller in here, even after surgery, the patient will not symptomatically improve. So maximum removal of the tumor, even if you cannot remove the tumor, then post-op adjunct treatment with radiotherapy will help the patient. Just going after endonasal dissection, opening the dural leaf, you will see the tumor, and once tumor is encountered, we can remove the tumor. Sometimes people remove the tumor in piecemeal, but if it is tumor like this, there is a good tissue plane. If someone is experienced enough to find out the tissue plane, then this tumor can be removed en masse. After removal of the tumor, we usually in such type of lesion where there is no CSF block intraoperatively, or there is no extended endonasal, then we can simply close with fat, fasciolata, and even here the Haddad flap or other flap is not required. This is the post-op scan. But this patient, after surgery, his growth hormone was high, so we used the adjunct radiotherapy. This is a case of very interesting case. You see here the planum tuberculum sella and planum sphenoidally meningioma. It's not the cellar lesion, but it's the planum sphenoidally and tuberculum sella. So the patient comes with vision problem. We went in through the nose, and yesterday Professor Babur was telling, as a otolaryngologist, we try to keep the middle turbinate intact. It's a very fantastic statement, and I like this statement. But sometimes if you need to go far enough, I think expanded endonasal. So expanded endonasal, we may, in that case, you have to dissect, or the basic thing is approach or surgical access. You have to go wide access. In that case, you may have to remove the middle turbinate or keep the middle turbinate as the reconstructive flap. Here we use the Haddad flap to close the defect. You can see here the tumor has come here nicely. So we could remove the tumor safely without cutting the skull. And it is a post-op scan. This is very interesting case. I don't know how much it will generate to you, because you are very. I can ask the expert here. What is the age limit of doing the face? Is there any age limit? Is kids you do the for children you do the face? Period is good. It's good. So this is a 4 years old kid who had craniopharyngioma and presented with vision loss of vision together with stunted growth. So you see the lesion is here, is the craniopharyngioma, and the pituitary gland is below. So the important thing is her pneumatization of the sella was conchal variety. So we have to drill the sphenoid to reach the cellar floor. After that, we have removed the lesion. Okay. So drilling the cellar floor, and then after going through the cellar space, supracellular region, we could remove the craniopharyngioma in the post-op scan. So As I have told you, few complications we usually face, but we have to keep in mind how we can deal this thing. And that's all from my side. And this is the hospital where we work. Thank you all. You all are welcome to visit our center.
Actually, these surgeons and these calvary surgeons are two brothers. They can move anyone with the help of others. So we run parallel. Thank you, Dr. Salek, for his nice and vivid presentation. And we are running behind of time, so we are not encouraging any questions, and this session will be concluded by this piece of Professor.
Thank you very much, Colonel MD Alami Salek. He's a neurosurgeon, you know. This is a endoscopic skull surgery conference. For this reason, possibly, although he's a neurosurgeon, he concentrate only anterior skull base. I'm thinking and I'm hoping maybe he gave some emphasis on also lateral skull base. Because you know I personally I can concentrate towards orthology, so I have some interest in lateral skull base. One thing I like to know from Colonel Salek, when we know pituitary, as long as it is microadenoma, it produces hormones and symptoms due to hormones, acromegaly or like that. And when it's more than 1 centimeter or like that, then it produces pressure symptoms, mainly in the optic chiasma. So, when we have to interfere surgically?
Okay, thank you very much, sir, for this question. For pituitary tumors, either micro or macro, so whether it is functioning or non-functioning, two group. If it is non-functioning, then more than centimeter, 1 centimeter or giant size, the patient symptomatic with visual problem, and there is some evidence by the perimetry that the vision is impaired, then for non-functioning one, we will go surgically. But for functioning one, either prolactinoma or other thing, usually prolactinoma responds with medication. Even pressure on the optic chiasm, we sometimes use the medication for prolactinoma. We have high threshold level for prolactinoma going for the surgery. So once medical management doesn't act or the medical management patient cannot comply, then we go for prolactinoma. But for acromegaly or pushing, even the size doesn't matter. Even smaller size, we go for the surgery. Thank you, sir.
Thank you, Dr. Thank you all. Thanks.
শিওর উপরে যাব নাকি?